Hi there, my name is Jeffrey Kong. I'm the cornea and contact lens resident at University of Houston College of Optometry. Today we're going to be talking about wiping away those teardrops because it's just acute corneal eye drops. Alright, just a little bit of introduction. As I said, I'm the resident at University of Houston College of Optometry. I graduated from UC Berkeley School of Optometry in 2021, and my long-term goals are to work in a private practice and participate in clinical education. So, my patient, a 41-year-old female, complained of a red, painful left eye with onset 3 weeks prior. She had significant photophobia and difficulty opening her eyes. She's a habitual scleral lens wearer, but as a well-educated patient, she stopped wearing her lens at the onset. Her pain was 7 out of 10, and she reports that her vision was very bad, but this is without the scleral lens. And now, if a patient called with these symptoms, but with a more recent onset than 3 weeks, what might your differentials be? I was considering, an ulcer, uveitis, maybe a scleritis, or even herpes simplex keratitis or zoster, but then you would look for those skin lesions. A little bit more history. A week ago, the patient went to her PCP who prescribed doxycycline, 100 milligrams by mouth twice a day, and atropine, 1 drop in the left eye twice a day. The patient reported that the atropine helped somewhat with the pain and helped her open her eye a little bit more, but even with that, the pain was still 7 out of 10 in office. Some ocular history. She has bilateral keratoconus since 2009 and a right 80s tonic pupil since 2013. She's also immunocompromised, being HIV positive since 2017 with an undetectable viral load, history of uterine cancer in 2020, anemia, and history of epilepsy. Okay, and here are some clinical findings. With the lens in the right eye, her vision was 20/40. Without the lens in her left eye, her vision was hand motion at 5 feet. The right lens had an adequate comfort, fit, and vision. With the left eye, you can note we noted 1 to 2 plus diffuse conjunctival hyperemia, scattered 1 to 2 plus PEE with diffuse microcystic edema and lots of swelling and pockets of fluid in the stroma. Anterior chamber was not able to be viewed, and our IOP was low at 4 with eye care, though that typically ranged about 7 to 8 with Goldman tonometry. Her pupil, right eye, was also minimally reactive due to her 80s tonic pupil, and the left eye was pharmacologically dilated with the atropine. Here are some images from that visit. You can see the frank corneal edema along with the pockets of fluid in the stroma. You also might note that the reflection here of the light is kind of indicative of the microcystic edema due to the irregularity there. Here's an anterior segment OCT, which just kind of shows the extent of the edema and the fluid infiltration to the cornea. You can also see the large pocket of fluid and potentially visualize the Brachen Decimase membrane at the bottom right. The plan for that visit was to continue the atropine and doxycycline. We're going to add on Tobradex to give us some antibiotic coverage due to the epithelial defects, as well as add the Steridon to help with the scarring. And we also added on Muro, which would help with resolving the microcystic edema, and we recommended over-the-counter ibuprofen for pain management. We instructed the patient to return in 1 week. About a week later, the patient came back having taken only the Muro, but not the Tobradex. She also presented to the emergency department a couple days after the initial visit for severe pain in the left eye. The emergency department recommended that she discontinue all drops and started her on loteprednol 3 times in the left eye and gave her Vigamox as well that she did not use. The pain and redness had decreased significantly with taking the loteprednol, and this image here kind of better highlights that microcystic edema you could see there. Here we can still see residual edema and smaller pockets of fluid. At this visit, we had her continue the loteprednol 3 times a day and start Vigamox 3 times a day in the left eye. We then we instructed her to come back in 1 week for follow-up. And a key pearl here is to really emphasize the necessity of compliance with your prescribed medications, as the patient could have saved a lot of trouble had she just started the Tobradex on the first visit. She would probably have not ended up needing to present to the emergency department, given that when she got on the loteprednol, her pain and symptoms reduced fairly significantly. We also advised the patient not to go to the emergency department again for this particular issue, as we could manage it appropriately. And here are some anterior segment OCTs that show definite improvement in the pocket of fluid from the previous visit, though there's still quite a significant amount of edema. A week later, her symptoms were improving with minimal pain or redness. She was still taking the loteprednol 3 times a day, but was only taking the Vigamox once a day, despite instructions to take that 3 times a day as well. She still had small pockets of fluid and diffuse microcystic edema, but minimal epithelial staining. At this point, given that she was already taking the Vigamox at a sub-antimicrobial dose, we decided to discontinue that and start a 3-week taper of the loteprednol, so 3 times a day for 1 week, 2 times a day for 1 week, and then 1 time a day for 1 week, then discontinuing after that. We decided to see her back in 2 weeks during the taper just to make sure that she was complying appropriately with our instructions. Here are some images that also show kind of the reduction in the edema and the pockets of fluid, but they're still present. And this slice of the anterior seg OCT actually didn't capture those pockets of fluid, but on the slit lamp exam you could still see them. This does show that there was definite improvement in the edema, but still some residual edema left compared to baseline. And here's another picture just kind of showing how some of the residual haze and edema has gone away, but in hinting at possible scarring that might be occurring inferior nasal. 2 weeks later, patient came back having followed our taper instructions and was now starting her last week of the taper of the 1 time a day for 1 week. Vision had improved from hand motion to counting fingers at 5 feet without the scleral lens. We noted a few mild pockets of corneal edema remaining, but she was definitely improved from the previous visits. At this visit, we decided to continue with the loteprednol taper, finishing it out over the course of the week, and then we'd have her back in 1 month to follow up, presuming that she'd be resolved by then, and we can assess the scleral lens in that eye once again. And at this visit, the slit lamp exam notes just the mild edema, but otherwise pretty much close to resolve there. And a video as well, just kind of getting you through the cornea a little bit more to show kind of the lack of notable edema or pockets of fluid. Anterior segment OCT also showed pretty much resolved edema and fluid at this point. So at her follow-up appointment, which she had no-showed to and rescheduled 3 times prior, we had finally got her back in to reassess her left eye for scleral lens wear. We noted that the hydrops was fully resolved, with notable residual scarring remaining, as you can see in this picture here. With her habitual scleral lens left eye, the VA was 2100, and with the SCOR, we could get that to 2080. Previously, she had been 2050 to 2060 in that eye with mild scarring. The lens fit remained adequate, so we discussed options for a potential refit, which might gain her, 1 line of potential VA improvement, or a potential option for a corneal transplant due to the increased scarring that was decreasing the VA. The patient was not interested in either option at this time. She preferred to monitor and was okay with the current vision in the scleral lens. We also advised the patient regarding the increased risk of recurrence of hydrops now that she had her first episode in this eye. Alright, let's move on to the discussion. So, in looking at this case, some of the differentials that I had were acute corneal hydrops, Fuchs endothelial dystrophy, given the edema, posterior polymorphous corneal dystrophy, which is autosomal dominant and affects the Descemet's membrane, but is quite rare to have edema. Also, iridocorneal endothelial syndrome, which presents with glaucoma, edema, and heterochromia, but given the low IOP and lack of heterochromia, this was lower on the list. And finally, we should also consider an infectious keratitis. So, some of the symptoms of acute corneal hydrops are significantly decreased visual acuity, intense photophobia, and pain. Our patient did present with all of these, though her VA was decreased more significantly due to the fact that she no longer was wearing the lens when this occurred. Some of the signs you're going to see are stromal edema, microcystic edema, interstromal cysts and clefts, and conjunctival hyperemia. So just to go over the pathophysiology of hydrops, it usually occurs with rupture of Descemet's membrane. This allows aqueous into the stroma and epithelium, leading to edema. One study did indicate that a break in the Descemet's membrane alone is insufficient to cause hydrops, as they did not observe hydrops in patients who had received a DMEK with keratoconus. However, they did note classic hydrops if the posterior stroma was accidentally punctured during a Bowman's layer transplantation, suggesting that the posterior stroma and the Descemet's membrane need to be ruptured for hydrops to occur. This disease is usually seen in patients with corneal ectasias like keratoconus, pellucid marginal degeneration, and keratoglobus. It's usually self-limiting over the course of 2 to 4 months, which we did see in our patient. Complications include neovascularization, infection, perforation, or scarring, and the estimated prevalence is about 2.6 to 2.8%, although recent studies have lowered that to about 1.63 per 1,000. Some risk factors include eye rubbing or any kind of mechanical trauma to the eye, VKC, atopy, Down syndrome, or rapidly progressive keratoconus. And in rapidly progressive keratoconus, eye drops will usually present within the first several years when they're that quick of progressors. And imaging is also a great way to track the progress of corneal eye drops. You have kind of two options. You can use ultrasound biomicroscopy, shown on the left here, or anterior segment OCT, shown on the right. Anterior segment OCT has several benefits over ultrasound biomicroscopy, including higher resolution, better visualization of the break in Descemet's membrane with an edematous cornea, and you can get the image without having to contact the eye, which is better for children or people who won't quite sit still for a prolonged time. The goal of treatment for corneal eye drops is to make the patient as comfortable as possible and to prevent any complications or comorbidities from occurring. You can add on a steroid to help reduce corneal neo and scarring. Topical hyperosmotics like Muro can help to reduce edema, especially the microcystic edema in the epithelial layer, although it's questionable efficacy in terms of the frank edema in the stroma, given that Muro typically affects just the superficial epithelial layer. Topical antibiotics can also be very important to help prevent secondary infections, and in our patient this was particularly key because she was immunocompromised. Oral doxycycline can also help reduce MMP9 activity, which can also help to prevent scarring. Cycloplegics will help with pain management from the secondary iritis, and pain management like oral NSAIDs or acetaminophen can help just to take that pain level down. Ocular hypotensives can help to reduce pressure on Descemet's membrane from the backside, which is thought to help increase healing time and reduce scarring. And vitamin C has also been shown in some studies to possibly reduce scarring and neovascularization. So just some clinical pearls. Eye drops is a possible and sight-threatening complication of corneal ectasia. And even with prompt treatment, scarring may reduce the patient's best-corrected visual acuity. Anterior segment OCT and photo documentation are also useful to help monitor disease resolution. Although not absolutely necessary, they do help kind of also show the patient that they're progressing as well. Here are my references. And a special thanks to Dr. Anna K. Logan, my program coordinator.